Okay, good afternoon and hello, everyone. My name is Thomas Stevenson, and I'm a new member of the Education and Professional Development Committee. And on behalf of the committee and CETA, thank you all for joining us today on this latest installment of the CETA webinar series. Today's topic is Beyond Certification, why certifiers should understand CAG-011 and CAG-013. It's a practical look at the two application guides that sit at the intersection of certification and sterile compounding competency, gloved fingertip testing, and media field testing. We'll explore how these two evaluations work together to assess garbing, hand hygiene, aseptic technique, and patient safety. And also what certifiers should understand about how their work connects to these assessments. Today's presentation will be delivered by Abby Roth. Abby is the Executive Director of Pure Microbiology with Premier Inc. and has been serving the pharmaceutical, medical device, and compounding industries since 2004. She's a recognized expert in pharmaceutical microbiology, specializing in environmental monitoring and sterile compounding. She's contributed to industry standards as a member of the USP Compounding Expert Committee from 2015 to 2020, and through her ongoing involvement with CETA. Just a few quick housekeeping things before we get started. If anyone is experiencing any sort of technical issues during the presentation, just use that chat feature and communicate with the CETA office. As for questions, if you have any that you'd like to direct towards Abby, please use the question box and we'll work through them during the Q&A at the end. At the conclusion of the webinar, a copy of the presentation slides along with the survey link will be emailed. And we'd appreciate any feedback you can provide. So with that, I will hand it over to Abby.
All right. Thanks so much, Thomas. Yep. All right. Welcome, everyone. So as kind of was mentioned here, we will be covering kind of this beyond certification piece and taking a look at some of the parts that we see in CAG-011 and CAG-013. For the rest of this, I'll probably be referring to them as 11 and 13 to kind of keep that clear. So I do have a couple learning objectives that hopefully at the end of this, you can walk away and have a better understanding of. So one is being able to explain the purpose of these CETA application guides and how each supports competency for sterile compounding personnel. Also, being able to differentiate between glove fingertip testing, media fill testing, and what each test evaluates. And I'm sure sitting here now, you're like, yeah, thanks, Ab. I can tell that difference. But we want to kind of elaborate on that a little bit more, especially as it applies to some of the competency assessments we see in the USP chapters. The last learning objective is then to apply key concepts from 11 and 13 just to help strengthen training, documentation, and then what goes on in the compounding environments. A couple of acronyms that will get used. You'll see these on the slides. I don't think anything here is too out of the ordinary. These should all look pretty familiar to us in the industry. So taking a look at these two application guides, we're dealing with 11, which is going to be on glove fingertip testing, again, specific to sterile compounding personnel, and then 13, which covers the media fill testing for sterile compounding personnel. Now, you're probably wondering why we're bothering talking about this related to the certifier, because when you think of your role, it's typically, I'm going to go in, I'm going to test the facility, maybe I'll do some viable sample collection for them, but why would this be something that really matters to me? And one of the things that I like to mention here is we do see this sometimes as a service offering that some certifiers are providing to their customer. And some sterile compounders are looking to outsource some of this or, all of it. So, one of the things to maybe take a look at is this a fit for you as an organization to include some of this as a service offering? And as I said, it might not be all of the testing, but it might just be maybe to supply media or to support glove fingertip. So again, a couple of things to look at there. One of the things, though, that is probably more important is the trending support. And USP 797 specifically talks about the need for sterile compounders to trend their personnel data and their environmental monitoring data together. So if you are currently a certifier and one of your service offerings is data trending for the viable air and surface samples you collect, is there an opportunity or a way for you to tie that trending in somehow into their personnel data? So again, something to sort of maybe look at as another way to be a partner to your sterile compounding customers. So as we narrow in on the scope of what we're talking about today with 11 and 13, again, 11 is glove fingertip testing, 13 is media fill testing, and kind of the weird part about how the CAGs are set up is that it's looking at the two types of testing, but then they kind of overlap when it comes to what goes on, specifically with the competency assessments. So we are going to be strictly focusing on these related to USP 797 and also 825. So if you have any radiopharmaceutical customers, they will also fall into this bucket as well. So I want to kind of get into what we see with the initial competency requirements versus what is required on an ongoing basis. And if you have any familiarity with USP 797 or 825, when you go start looking at those chapters, we're seeing very clearly defined information for garbing and hand hygiene competency, but also the aseptic manipulation competency. So let's focus on the orange table that is there. So the initial competency requirements. Before somebody is going to start compounding, they have to complete this garbing and hand hygiene competency at least 3 times. So it's a significant undertaking when somebody does join a sterile compounding organization to get them through some of this training and these assessments. It's done 3 times and they need to pass consecutively. So that means that if they are tested and they pass the first round, they pass the second round, and they fail the third round, they need to start over again and complete 3 more rounds in order to be able to be considered competent. As part of this, we have a visual observation and also glove fingertip testing. The aseptic manipulation competency, which would happen initially, also does have an observational component to it. And there's no replicates specified. So it's not like they need to do this 2 or 3 times. It's a one and done. It does include a media fill test, a glove fingertip test, and surface sampling is required for USP 797 only. And I'm just going to pause here a second just to explain one detail in that. If you think back a couple of years ago when we were waiting for USP 797 and 795 to be released, 825 was also kind of in the works at that time. And what we saw in 825 looked very similar to what we saw in 797. And then 797 was remanded and went back to the committee for changes, but 825 continued through. So you are going to see some significant differences in some of the testing requirements for what is required for 825 versus what is required for 797. So we'll highlight some of those things today as we continue the discussion. Now we'll go over to that blue table. So our ongoing competency requirements, they look very similar. Really, our only difference here is the glove fingertip testing with the hand hygiene and garbing happens once on the ongoing basis that is required. And then the aseptic manipulation competency looks pretty much the same. So kind of looking at that and thinking about that previous slide about, is this something that maybe the certifier would be interested in offering? There's a couple of things to consider. So you do need to be able to probably not only support supplying media fill tests and doing glove fingertip testing, but also supporting the observational portion of this. So a lot of times the sterile compounders are looking to outsource that as well, where they don't want to have to do the observational portion and you're still, in there helping with some of the sample collection. So that would be a key component to this that you'd want to include. And then also needing to think about the level of support. So when you're working with the sterile compounders, and I'm sure some of you have experienced this, where maybe things that they do are very generic. You look at their SOP, you look at what's required, and it pretty much is like, hey, we're meeting the bare bones requirements of USP 797. And for some locations, when it comes to garbing or it comes to media fill and aseptic competency, they're just meeting bare bones, right? Their observational checklist for this is, are we sanitizing gloves? Check. Versus some locations really want to go a little bit on that deeper dive of, are they meeting the specific facility SOPs? So I bring this up that if you are going to want to get into this and to support this, you probably are going to need to be prepared to be able to assess to their particular SOPs and not some sort of kind of just generic checklist. So those would all be things to consider and think about. The other piece of this is, as I have seen some certification companies start to offer this service, they are actually hiring pharmacists or pharmacy technicians to help oversee this service offering and then to also help deliver it out in the field. So totally doable, but there is going to be some question along the line here of like, what training and competency does exist for the evaluator that is going to be doing that? All right, so we're going to get into the details of glove fingertip testing. And as we talk about this, we'll talk about some of the 797 and 825 requirements, and then also see what the CAGs tell us as we're looking at this. So media that's going to be used for glove fingertip testing is going to be contained in some sort of a device that has a general growth medium. So we are usually using TSA. It does also have to contain neutralizers. So that's where that lecithin and polysorbate 80 comes in. Remember, if you're using something that is marked as P80, tween 80, T80, it's all the same thing. So we're good there. The devices themselves, typically we will either use contact plates or settle plates for glove fingertip collection. There are other devices available and out there, such as contact slides and paddles. The CAG actually focuses more on using contact plates and settle plates, which better aligns with what we see in sister industries and aseptic manufacturing environments. One of the key pieces to this is, regardless of what you use, we do want to ensure that the individual is able to adequately roll their fingertips over the media surface. A little bit of overlap is fine because I know it can get tight on a contact plate, but we don't want to have like all of the fingers in the same area. So a couple other media considerations here, and this is information coming out of the CETA application guide of looking for media that is irradiated. The reason for that is that in case there's a failure and now an investigation needs to happen, we want to be using media that we know is sterile. Because if we started with something which was, as we know, as aseptically filled, that could end up resulting in microbial contamination. And now that's an area that would have to be investigated in the event that there was a failure. Being triple bagged. So that also indicates that the media is made for cleanroom use. So I want to talk about those like top two things here just for a second, where irradiated media and triple bagged, again, it's guaranteed to be sterile to start, and it is going to be appropriate to shed a layer and transfer it for use in a clean room. The alternative to that is aseptically filled media. So think of that as what goes on in sterile compounding. They start with a sterile drug and they're trying to maintain sterility. It's the same thing. The manufacturer at this point is starting with sterile molten media, and they're pouring it into sterile plates and hoping that it stays sterile across the way. Unfortunately, I have seen situations where that media ends up not being sterile and it has some contamination incidents. And media that is produced that way is really meant to be more used in a lab setting than it is in a clean room setting. So what you're seeing on the right-hand side of the screen is information that comes out of USP 1117. And that is the USP chapter on good, microbiology lab practices. And it does tell us in there that if you do use aseptically filled plates, it requires 100% pre-incubation. So you're probably wondering, like, what does pre-incubation mean? All that would mean is that when you receive your media, typically aseptically filled plates require refrigeration. Instead of sticking them in the fridge when you get them, you're going to leave them out at room temperature for about 48 hours. That way, if there is contamination, you're giving those organisms a chance to grow out and be visible. Because if you left them in the fridge, they're not going to grow until they're brought up to room temperature and then thrown in the incubator. So hopefully you're seeing why that could be a concern. So again, leave them at room temperature, stick them in the fridge after you hit that point, and then prior to using them, you want to make sure that you are checking them for use. But all of that can be avoided by using irradiated plates to start. Last few things that you're seeing on the slide here tie into storage conditions. Stuff that's irradiated is room temperature storage, usually makes it a lot easier for you. Usually some longer expiration dates, generally 6 months from manufacture. And then definitely looking for locking lids if that's an option. And then you do need to have a certificate of analysis on file for every lot of media that you use. So getting into the testing technique here is we want to use one plate per hand. Like we can't get, tricky here of like, I'm going to save some money and put as many fingers on a plate as I possibly can. So that's not the idea here. So it's going to be one plate per hand, or if you're using paddles, it would be paddles per hand. We want to do this in a rolling motion over the surface, and we'll show you a video here in a second, sampling the pad of the finger, and we want to have adequate pressure. So anybody that's been in the industry for a number of years and you've either been tested or you've been supporting testing in manufacturing environments, I always think of like the T-Rex type of testing that would happen with glove fingertip, where like people just kind of dab their very like tips of their fingers on the plate, and we're not getting that good rolling motion with the pads of the fingers. So gone are the days for that. And, the CAG and USP really define what we should be doing there. Also, there should not be any spraying of gloves with 70% alcohol before we collect the sample. So that's kind of defeating the purpose of what we're trying to capture, whether it's after gloving, so can they get gloves on without contaminating them, or after the media fill test, where it is, were they able to maintain low bioburden on their gloves? So if this is something that you are currently doing, a word of caution here, there are some very strict requirements in 797 for labeling plates. Abby Roth's opinion here, I don't think that some of this is necessary, but that's where we are. Best practice piece for labeling is I would like to know what the type of sample is. Is this ongoing? Is this initial? That could be valuable. The chapter does require the hand. Again, that is important information, whose it is. And then the chapter also requires the date and time to go on the plate. And I always think about this of like, but I'm going to throw the plate away. So whatever important information that I'd want to capture and have as documentation somewhere should go on paperwork. And being on the plate maybe isn't quite as important. But that's what we're dealing with as far as a requirement. So here's our summary related to glove fingertip testing that would happen after garbing. So again, this would be part of the hand hygiene and garbing competency. The whole purpose of this testing is, can staff get gloves on their hands without contaminating them? And this would be for anybody that is going to be doing any sort of compounding. There's some flexibility within at least 797 for the organization to decide what sort of other training might be needed for other individuals entering. So there's some flexibility with that. Anybody that's going to be compounding what's defined as a category 1 or category 2 medication, they're doing this initially and at least every 6 months. Category 3 is at least initially and then every 3 months. And you're going to see here where we have that big difference with 825 in that this is initially and at least every 12 months. So it's a little less stringent when it comes to anybody that's going to be on the radiopharma side of things. This gets done where gloves are donned. So if you think about the places that you go service, some locations have you don gloves in the ante room. Some locations have you don gloves in the buffer room. Wherever the gloves are donned is where this testing would occur. Now, if you end up going to visit people that have segregated compounding areas and they only operate in a CAI or a CACI, the RABS units, then they're going to be testing the gloves that they put on over the RABS gloves inside of that device. And that gets super complicated, but that would be the expectation here, that we're actually testing those gloves. Our action level here is anything greater than 0 CFU per both hands. And as I mentioned previously, they need to pass consecutively. So I want to share a quick video here of kind of what this will look like, especially if we're talking about non-hazardous compounding. So we're in the non-HD buffer room. And again, this could be in an ante room, it could be in a buffer room, but with labeling, we're seeing the initials go on for that individual, the hand, the date, and the time. And again, depending on what type of sample it is, that might be something else that we are adding on there as well. Alcohol is super important as we're administering this test. It's the same as you'd be handling any sort of plates for air and surface collection. So that individual just donned gloves. We're going to present the plate to them at an angle, at a nice position where they can roll their fingertips over. And if they're not rolling over, you can supply some feedback and ask them to do that. The other nice thing about holding the plate is now I can tell what type of pressure they are putting on that plate. You'll kind of see that the person holding the plate in there, like their hand has some give. So if they're pressing too hard, I'm trying to avoid them breaking the media. And if they're not pressing hard enough, which I've come across where it's like, can we ghost this plate and not touch it so I pass my glove fingertip testing? You're able to feel that and know whether or not they're applying adequate pressure for recovery. All right, so we'll transition to talk about the glove fingertip testing that now happens after the media fill test. So the purpose of this is a little bit different. This is, can staff keep the microbial bioburden low on their gloves while they are compounding something? So in this case, it would be that media fill test. This will be done for new or tenured staff. Again, categories 1 and 2, it's initially in at least every 6 months. Category 3 is initially in at least every 3 months. And then 825, still, it's that annual basis plus initially. The one other thing I'll mention here, and as you dive deeper into 797, things get a little bit more complicated for people that are compounding versus people that are overseeing compounding. And those that strictly oversee but don't compound are only required to do these types of tests on an annual basis. So again, if you're supporting a pharmacy in this sort of work, it's going to be critical that you talk to them about who needs it at what frequency and making sure that, we're meeting their needs. This gets done though in the primary engineering control. So after they've completed the media fill test, that is where they're going to be tested. And we have some more flexibility here with our action level. So this would be then anything that is greater than 3 CFU per both hands. So again, we got a video. Again, this is, I'll just be real here. Like, this is not actually going on in a compounding facility. This was all staged for the videos, but it's to just give you an idea of what is going to kind of be happening here. So the plates for this were already staged off into the left side of that primary engineering control. Finished the media fill test. The person that's going to administer it sanitize their gloves with alcohol and is diligently ensuring that they are dry before they go and enter. He's going to take the surface sample first. And the reason for that is that if he was going to put the glove fingertip plates down on the surface for me to be tested here, I wouldn't want to have any contamination concerns. So surface sample happens first. The glove fingertip test, he is holding the plate while that is occurring, again, being able to feel the pressure. It's really important too that you notice that the lid is not coming out of the PEC. Sometimes as we're getting kind of cozy and close to one another to do this testing, that hand will kind of gradually get pulled out of the PEC, and we want to avoid that. So at this point, the person that got tested, they'd be able to take off their gloves, get new gloves on, and start cleaning up post-media fill. Now, this individual who administered the test at this point is going to label the samples. And The labeling is happening after this because, again, in order to eliminate contamination risk, all of these plates are being transferred in prior to testing so that we're not like wiping them down with alcohol, because we certainly don't want to do that. And again, trying to eliminate some contamination risks here. Okay, so this is interesting because we definitely want to have controls when we do environmental monitoring, but when you look at CAG-011, it talks about controls for glove fingertip testing, and it does break it down into both a positive and a negative control, and I'm just going to bring them both up here. So in this situation, again, positive control is really beneficial when we are going to be shipping things to a contract lab to show that the conditions from storage through shipping has not impacted that media's ability to support growth. And the lab will typically then follow USP 61 for the organisms that they will use to inoculate that control. The negative control is to give us some level of assurance that the plate was not contaminated during handling and sampling. So when we talk about the negative control, it's going to be removed from the outer packaging. It's not like we're just sending a whole stack of plates to the lab in its original packaging and saying, here, use that for the negative control. Again, that kind of defeats the purpose. At that point, all we're proving is that the media is sterile, not that you in handling the plates are able to show that you were able to do so in a manner that didn't contaminate them. So that's kind of how that would work with the controls for this if it's something that you're going to do. For pharmacy incubation, so if you would go and service your sterile compounding customer, do this testing for them, and they're going to incubate themselves, I don't know that there's a huge benefit to a positive control for this because they have the C of A on file, which should show that the media supported growth, but a negative control might be beneficial here. Lab incubation, this is a great time to discuss what the lab will support. Sometimes they will charge for controls, and maybe there's not a benefit to doing a positive and a negative, but the CAG does talk about having a positive and negative control per lot of media and per shipping container. The per shipping container thing is if you're doing a whole bunch of samples and they need to go into 2 boxes, you want controls for both boxes because there is a good chance that they will not end up at the same location at the same time. In the event that you're not going to do controls, sometimes the contract lab, and when I say not do controls, maybe you don't have controls to send to them, they might be willing to use plates post-incubation to inoculate to show that they would support growth. So you have some different options and can work with your contract lab on that. Just a bit on incubation here. So for USP 797 and 825, we are incubating at 30 to 35 for at least 48 hours. Notice that there's not a requirement to count and record the number of CFU after that incubation. And then you transfer to the next incubator, 20 to 25 for at least 5 days, count and record. Anybody that is doing this, whether it's the certifier partnering with a lab or pharmacy doing it internally, please, please, please read the samples after that first incubation period, because most of the bugs that we're going to be recovering, which are from people, should be showing up in that first 48-hour period. Now, as we compare that to what we see in 11 for incubation, you're going to notice temperatures are exactly the same. We do see that we want to count and record CFUs after both incubations, but you'll notice that there is a range here. And that range can sometimes help reduce the risk of media desiccation. So for CAG-011, it is 48 to 72 hours. And then for the 20 to 25, it's going to be that 5 to 7 days. So that's something that can certainly be worked into. Maybe it's not in your SOP, but at least everybody that's trained to read media does follow that. So we'll transition to the media fill testing here. And this is really important because it's the only objective way we have to test aseptic technique. But there are significant limitations to this. It is certainly not perfect. So the 2 big limitations that I wanted to just touch on is the term probability of a non-sterile unit, or PNSU. You might have seen this referred to as sterility assurance level, or SAL. And really all of that is saying that something that is aseptically filled has the probability that 1 in 1,000 containers prepared will be contaminated. For things that are terminally sterilized, now we're looking at, that kind of risk going down, where it's 1 in a million have a risk of being contaminated. And remember, aseptically filled or aseptic processing for what we do as sterile compounding would include sterile drug into a sterile final prep for the patient, or starting with a non-sterile drug and then a sterilization step through filtration. So those would both be considered aseptic processing, and that does increase our risk for contamination. Also, statistically, when you start looking at numbers here, in order to be confident that you're not having this sort of like level of contamination, you'd have to compound like 3,000 media fill units. And nobody is going to do that. So it's very hard to get that like statistically significant data to show that you have a state of control. The other part here is this term viable but non-culturable microorganism. And I think for a lot of us in the industry, we tend to think of TSA, TSB, it's going to support all of the microorganisms, everything is going to grow. And yes, kind of on paper, it will support a variety of microorganisms, but that doesn't always mean that they're going to grow for us. So we might have instances where bacteria or microbes are alive, they are metabolically active, and they do not grow under the laboratory conditions that we give them. And it could be that they're injured because of getting hit real hard with cleaning agents, or it's just something we picked up that doesn't like 30 to 35, doesn't like 20 to 25, and doesn't like the media that we're providing. So that's going to kind of come back here as we continue to talk about these media fill tests. So take a second. You don't have to put it into the chat or anything, but just to yourself, look at this. Which vial would pass a media fill test and why? So based on what you know about media fill testing, which one would pass? I'm sure hopefully all of you are saying the one on the left, because that is the correct answer, right? Because we're not seeing turbidity in that container like we're seeing in container number 2. But one of my words of caution here is that it takes at least 1 million bacteria per milliliter of broth for that turbidity to be detected with the unaided eye. So we're talking about a lot of microbes. The other thing that I want you to understand is when we use the term clear, where we say that the media is clear, that just means that there was no visible growth. It doesn't mean that that container wasn't contaminated. And that goes back to that viable but non-culturable organism, where we could have gotten organisms in there, but based on the incubation conditions provided, they didn't grow out. And sometimes, even though we incubate media fill for 14 days, sometimes these bugs might not show up to day 21. And it just depends on that particular organism, how happy it is, and whether or not it's going to want to grow under the conditions that we give it. So take the media fill for what it is. It's a quick check, quick snapshot of what that individual is doing, but it in no way definitively shows that we have a state of control over compounding. I wanted to share the USP design requirements before we talk about what's in 13. And when you take a look at what USP tells us, we're supposed to closely simulate frequently used complex manipulations. Okay, great. So, things that we do a lot and things that are more complicated. It also goes on, though, to tell us that it has to capture elements that could potentially affect the sterility of the CSP. And it gives us a couple of examples, but then does use the word not limited to. So that language really indicates that it's important to look at the overall compounding workflow and the compounding process and to identify all of the risk points that exist that need to be addressed. So when we're looking at this, we're looking at factors associated with the length of the process, how many transfers or additions do we have, what's the number, the type, the complexity of the manipulations. And I think the last bullet gets missed all the time, where we also need to take into consideration the number of personnel that are in the buffer room or in the SCA. So if the normal operations is there to be like 4 people in a buffer room, we want to simulate that during the media fill tests. So it's an important piece to include here. Now, this is what 13 tells us. And a lot of this kind of ties into some of those pieces in USP, but as you know, USP tells you like what to do and not how, and that's where the CETA application guides are there to kind of bridge some of those gaps. So working in automated compounding devices. Do you use a repeater pump? Is a TPN compounder used? Is there other compounding equipment that is part of this? We want those things included in the media fill test, or at least in some sort of process verification to show that, yes, we can produce sterile medications using this equipment. Including any sort of specialty attachments. Great example here would be closed system drug transfer devices, or CSTDs, that are used for hazardous compounding. That adds a layer of complexity to what is going to happen, and that should be something that could be considered. Delays in the compounding process. And I think a really good one of those to think about right now ties into the IV workflow technology. So you as certifiers, I'm sure you've gone into these pharmacies and there's a whole bunch of camera systems, gravimetric scales, and things that are now in a lot of these primary engineering controls. Well, with those, there's going to be pictures that have to be taken. Sometimes things need to be verified, and there's a little bit of a delay in the compounding process as part of that. Those are some things that should be considered as well. Diversity of vessels. So we're talking here about the final container closures. Are we talking bags, vials, syringes, cassettes? What is that final medication going to go into and out to the patient that we want to capture as part of the media fill? I had a location that I was working with where everything that went out the door was in a cassette. So their final container for all of their media fill tests was a cassette. Simulating manipulations. So again, trying to capture a lot of what would go on with reconstitution and maybe additional transfers that would occur. Use of ampules, if that's something that's also part of their process. Transferring of medications into final containers. And then the type and size of the PEC. So, you know, a lot of the individuals that will compound will do both hazardous and non-hazardous. And now we're talking about horizontal airflow versus vertical airflow and capturing the difficulties that occur in both of them, right? Because the compounding will look very different. Just a little bit here on the final container closure, and this information again is in 13, and it does talk about that any type of CSP final container that personnel could be expected to compound should be considered in the media fill test. So very often kits will be purchased, commercially available kits. The final containers in those kits maybe as a bag or maybe as a vial. And if that's not really what is going to be going out to the patient floor, we do want to be trying to capture that in the media fill test. The other key piece here, and this was for the microbiologists that are going to be analyzing these, or even for within the pharmacy, their staff, we want to have enough media in that final container so that we can actually visualize turbidity. So having at least a 10% capacity of that media fill, of that media to the container is helpful for us to be able to do that. The test media that we're using for this, it's going to be TSB, so tryptic soy broth. Anybody doing a sterile to sterile simulation is going to use a sterile broth. Non-sterile to sterile is going to start with a powder and sterile water, and then they're going to sterilize that in the process, usually with a filter. We still need to have a C of A on file for this. And this note comes out of USP 797, but please, 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 please don't get any ideas where you're going to start making your own media in order to do this. Commercially available media, please, to buy that. Otherwise, you have to do growth promotion testing, and that turns into a kind of a big mess. So in preparing for this, this language, again, comes out of 13. Personnel must be trained on proper clean room behavior and aseptic technique for compounding CSPs, right? That's kind of your basic need before somebody is going to be going through this media fill test. One of the other things that the document recommends is that each person tested should be given the media fill procedure for review prior to testing. This does not need to be some sort of crazy secret. Let them see what they're going to be doing. And actually, it's great to give them a copy of the media fill test so that they can follow it while they are doing it. Because remember, in real life compounding, they will have access to the compounding record, and that will tell them step by step how to prepare that medication. Giving them the actual media fill information on a laminated card is great because then they can kind of simulate what would happen when they'd be following a compounding record. Last piece of this is that this should just be very clear and concise, and should be closely representative of the actual manipulations that are performed. So a couple more pieces here out of 13. You do need to observe. So anybody that is administering the media fill test is to observe personnel looking at aseptic technique, overall clean room behavior, and that should be captured somewhere in an observational competency document. The middle one I think is super important, and I've been a part of and I've watched media fill tests, be administered. There should be no reason to give these people step-by-step instructions, or to tell them, please get a 20 ml syringe and you want to get an 18 gauge needle. That is all information that these individuals should know if they are going to be preparing medications. So kind of in the steps that you would give them ahead of time, you should not be telling them what syringe to use or what needle to use. They can make those decisions, and they should know that based off of their education and knowledge. Appropriate support here can be important. If somebody is always going to be in the room overseeing compounding and this individual has a question while they're doing the media fill test, they certainly can ask. But if most of the time they're left on their own and they don't have access to somebody to ask questions, that's also something you'd want to capture as part of the media fill, where they should really be self-sufficient and be able to complete that process on their own. So back to controls. This looks very similar to what we saw with glove fingertip. So I'm not going to spend a whole lot of time going through this. The only difference here that is, instead of sending out plates, we're going to be sending out an unpunctured container of TSB for our negative control. And I'm not sure that that's really even valuable so much, because as long as you have the C of A from the manufacturer, broth is a different beast. It sits out at room temperature. If it's going to be contaminated, you're going to know that ahead of time. So I don't know that a negative control is necessarily very helpful, but sometimes maybe doing a positive control, or at least a one-time showing that that broth can support growth, could end up being valuable. But again, this is the information, again, that we're seeing out of the CETA application guides. Incubation here, we have two options. We are either incubating at 20 to 25 for at least 7 days, analyzing it, and then transferring it to 30 to 35 and analyzing it, or we do the opposite. We start with the warmer temperature and transfer to the cooler temperature. So that is what 797 tells us. Here's where things, again, get a little interesting. The CETA application guide and 825 are very prescriptive in the incubation order. And they tell you to start at the lower temperature and go to the higher temperature. And you might be like wondering, well, why does that really matter? Well, it does match FDA's aseptic processing guidance for industry. So FDA has a document out there. You can Google this, find it, and you will see that if you do a 2-temperature incubation for media fill, they recommend starting at the lower and transferring to the higher. So we already have industry guidance on that. That's why 13 kind of leans on that. And that's also, I think where 825 was leaning on that as well. All right, wrapping this up here, we're close to getting through this. Media fill analysis, we're looking for turbidity or other visual manifestations of growth. And growth is the key word here. It is not particles. It is microbial growth is considered a failure on or before day 14. Please do not take these, though, out of incubation before that. Both 797, 825, and the CAG read that we are completing a full 14-day incubation. And there's good reason for that. If for some reason you did decide to identify the organisms in the media fill test, which is not a chapter requirement, it at least gives all of those organisms a chance to be able to grow and to be detected. Now, I did mention particles. That does not cause a failure. So sometimes we'll see vial coring. So some of the vial septum will end up in the container. We'll see other plastic floating filaments, especially if we're talking about bags. And then it's up to the organization to decide how they want to handle particles in there. So these are a couple of suggestions from 13 on what to do if we have media fill failures. Definitely review evaluator comments. If we can go back and see that that individual struggled, those are some areas that we can now focus on when we're doing some retraining. Also searching for external interference. And that could be things like, did we have issues during incubation where maybe there was a chip or a crack or something that happened to a media fill container that has now caused it to be contaminated? Were there issues upon receiving media fill samples in the lab that could have interfered? And then definitely do some retraining on aspects that might be concerning. And then we are going to have to do a retest here. So this question comes up quite a bit, and I think as certifiers, it does help for you to kind of know what the chapter says on this in case it comes up and you get asked, because I know sometimes you get asked some very interesting questions and get involved in some different areas. Does a failure require removal from compounding? So if they fail the media fill test, do they need to be benched? And based on 797, it is up to the designated person to decide, and that is also based on facility SOPs. So there's nothing in the chapter that says an individual fails the media fill test, they need to be removed from compounding. It should be based on their experience, past media fill test results. A great example is that you have somebody that is new to the organization, they pass their initial media fill test, and they do their 6-month requalification, and they fail then. Maybe I'm going to remove them from compounding, right? They're newer to our organization. They might be newer to compounding. That could be a good rationale, or reason to do so. Anybody that has recurring failures, or if there's recurring failures among multiple staff members, then we should be doing some sort of investigation. Is there a systemic problem that exists? And then an identification of growth could potentially be helpful. Even though it's not required, sometimes that will be beneficial to us when we're doing a root cause analysis. All right, last couple of pieces here is on documentation. So things that are going to be collected at the time of documentation. So if you are the certifier are helping the pharmacy do this, we want to know where you were, address, room location, like where was all of this happening? Who is evaluated and who you are as doing the evaluation, the date and the time, and then we also want to capture all of the media information. So what did you use, the manufacturer, the lot numbers, the expiration dates, all of that should be captured. We also want to know what components we're using. So if we're using pharmacy-specific empty bags, vials, get those lot numbers and expiration dates documented so that in the event there might be a recall or an issue with one of those lot numbers, we can trace that back. And if there was a media fill test failure, we can maybe discredit that as being an issue. You need your certificate of analysis for the media. Purpose of testing. So is this initial? Is this ongoing? And then clearly defining the action levels for the glove fingertip samples that are being collected and possibly sent out to the lab. Now, I'm partnering with a lab for this. They're going to provide some documentation here as well. So their information, the date the samples were received, that's important because hopefully things are going overnight and next day and not getting lost in the shipping process. Who's going to read and document those results? And again, that can be in the raw data. It doesn't necessarily need to show up on the final report, but as long as that information is accessible to you, that is something that will be key. Your total microbial count in appropriate units for glove fingertip, the results of each media fill test container. So if the media fill test is going to generate 5 units, we want individual results for each one of those 5 units. And that can sometimes also be valuable if there's a failure and we're doing an investigation. Incubation temperatures, dates, and times, the results of any control testing, and then an overall sample status with pass or fail. A couple other pieces here, look for deviations. So if there was any deviation during the actual test administration, and we see that in the documentation, or if there was deviations at the lab, something was dropped, there was an issue during incubation, you want to have that information. Again, that can help with investigations. Signature of facility management and data review. So the designated person that's receiving this should be taking a look at all of the documentation and signing off that, yes, this is meeting our needs, or we did not pass and we need to do an investigation, whatever that looks like. And then they also should have in place some actions to take in the event of an exceeded action level. So want to just wrap this up and then we'll have some time to take a few questions. CAG-11 and 13 can be valuable resources for certifiers looking to offer additional services. And hopefully that is something that, you can take away from this, that maybe it's not something that you want to offer, but you at least have a knowledge and foundational understanding, because I know a lot of times you're asked questions and it is something I think that all of us in this industry want to be able to help our customers and our clients, and just having basic understanding can help you do that. Providing competency assessments does come with responsibility. So again, if this is something that you are maybe looking to do as a service offering, the regulators, so the state boards of pharmacy, the accrediting body inspectors, they are going to want to see that you have some sort of appropriate education, training, and competency for those that are doing these evaluations. And I'm talking to you mostly as certifiers, but that would be the expectation too for pharmacy staff, right? They should have the appropriate education, training, and competency to evaluate others as well. So I did allude to this earlier, but it's always good to have this reminder that the compounding chapters lay the groundwork for compliance, but a lot of times they do lack specificity for successfully executing some of the things that they ask of us, specifically for glove fingertip and media fill. I think there's a lot of gaps, and that's where these CAGs hopefully come in and are, providing some additional information there. So there were some references that I did use for this. So obviously the CAGs, I mentioned that aseptic processing document from the FDA, a couple of micro resources, and then obviously 797 and 825. So thank you very much. I am going to pull up the question panel and see what we have in there, and we will kind of go from there. So just give me one moment. Okay, so first question was, can you explain best practice for conducting the glove fingertip testing in a 2-sleeve compounding aseptic isolator? And if the facility also has an HDBSC, does the testing need to be performed in the HDBSC and the LAFW? Okay, so I think I got it. We got 2 questions in one question. So I'll start with can you explain best practice for conducting glove fingertip testing in a 2-sleeve compounding aseptic isolator? Yes, and I want to again preface this of this gets complicated. So that individual needs to test themselves. So they are going to have to transfer in their media, and they're going to have to transfer in the gloves that are going to be worn. Now, certainly, if I was going to administer this test, and Thomas, I'm going to use you as an example, right? So Thomas is the compounder and I need to test him. I could certainly go in there ahead of time, get all of the media at least in and staged. The containers will not be opened, but we will have plates that are in there that individual can utilize. And then when he's ready to go ahead and start this, he is going to put on a pair of sterile gloves over top of the RABS gloves. And it is very important that as he is doing that, he is avoiding contaminating the paper that we're using for that gloving, because that sterile paper that the gloves came in would then be the barrier between his glove fingertips. Paper would be in here. You know what? I had a napkin. We're going to improvise here. So I would then use that paper to help take the lids off of plates. And then he could test himself as he was doing that. And then once he's done, he can put the lids back on, and then we're going to transfer everything out. So that actually takes some practice to get the individual to understand what they're going to need to do in order to make that happen. All right, so next question is that the facility has an HDBSC. Does the testing need to be performed in the HDBSC and the LAFW? So that's a great question. And again, there's no guidance from 797 here. So I'm speaking off of industry experience and knowing what a lot of the state boards and the accrediting organizations are accepting. So Usually, what they're liking to see is that initially for an individual, they complete their media fill test in both a biological safety cabinet and an LAFW, right? So you're doing your non-hazardous process and you're doing your hazardous process. From there, then on an alternating basis, you can do one media fill test in the LAFW, and then 6 months later, you do your media fill test in the BSC. And you can continue to alternate that way. Because the chapter doesn't get into being explicit and you need to do it in every PEC type every time. And we are finding generally that this is being accepted by state boards and the accreditors. So that was an excellent question. Next one was, how do you check for turbidity in a cassette? So in that case, yeah, you can't really see in there. So you actually are going to have to remove an aliquot of that broth and put it into a clear container. So just transferring it into a clear vial would be a great option for you to be able then to analyze that. And we are not concerned about drawing that broth out of that cassette and putting it into a vial for that brief period of time. There will not be any cause of turbidity in that short of a period. So excellent question. All right, what expectations are you seeing for pharmacies for certifiers to host, store, and document these records? So I'm trying to think of the best way to sort of answer this. If this is something that the certifier is going to provide to the pharmacy, again, I think maintaining and creating these records, they're looking for very similar to what they would have in place, right? Is there an SOP in a system where you collect that information, it is stored securely, so something that's retrievable and maintained for a set period of time. Obviously, you're going to have to provide them with documentation of the whole process, but that would be something that you'd want to have on file as well. I'm not sure that I'm fully understanding the question, but I would say, if you service anybody on the GMP side of things, I would keep all of the documentation that you do for the pharmacies very similar to what you do for your GMP customers. Okay, so the next question is spraying gloves with IPA allowed during the media fill validation? I don't like using the word validation because we're really not validating anything, but during the media fill test. So let's step back and think about what happens during compounding. So an individual is going to spray their gloves with alcohol, transfer their materials into the primary engineering control, spray their gloves with alcohol, and bring their hands in to do their work. That is allowed. So they certainly can do that all the way through. Maybe they're doing their media fill test and they realize, oh man, I forgot to bring in a needle or a syringe. Hands go back out, they grab what they need, hands get sanitized again as they come back in and do their work. So yes, they can sanitize their gloves during the media fill as they would normally do. What we're trying to avoid though is, them getting to the point where they're on their like last manipulation, and then hands are gonna leave, sanitize, and come back in and get tested. So usually if I'm involved in the administration here, I'll give them a warning of like, hey, these last two manipulations, you're not going to be able to remove hands and sanitize gloves, and then we're going to test you after that. So we're trying to still keep this very much similar to what we would actually see happening, in the compounding environment. All right, I think that is everything for the questions. So Thomas, I'll turn it back over to you. Thank you, everybody.
Okay, great. That was great. That'll do it for us today. Abby, thanks for sharing all your expertise with us and the CETA community. Thank you to CETA and Capitol Hill Management for all the technical resources that make these webinars possible, and the Education and Professional Development Committee for continuing to drive this webinar series forward. I believe the next tentative webinar will be on CAG-016 ORs, and I believe a date will be announced when we know more. As a reminder, the survey link and slides will be emailed to all of you afterward. So please share your thoughts with us. Also, the webinar recording will be posted to the CETA International YouTube channel. Thank you again, Abby, and everyone who joined us today. I hope to see you guys for the next webinar. Thank you.